Great, thank you, Jamie. So today is the first of three webinars that we have been asked to put together really to support the concept of shared care for our children with ADHD. This first session is an introduction to this. Jamie's done a beautiful acknowledgement of country. And just to say that all of our presentations and all of our work are in alignment with the CARD's values. So in this first of three webinars, we're going to present an introduction to ADHD, and our aim for this webinar series is to ensure that all GPs know where to go to access resources and support for their care of children and families with ADHD. I want to be very clear that this is not a training program for the diagnosis of ADHD, nor for the initiation of medication. The focus of our series is on safe, effective shared care. So we define shared care, and this is from the RACGP, as joint responsibility for planned care that is agreed between healthcare providers, the patient, and any carers they'd like to engage. And previous work that I've done on defining shared care with our GP colleagues includes our continuity of care between our services. We need to have clear definition of roles and responsibilities. We're really clear about structured management plans and ensuring clear channels of communication. So today's webinar introduces a clinical case, which we're going to build upon in the series. Today, we're going to talk about stimulant prescribing, and we're going to work through a stepwise approach. So our first case study is drawn from my caseload, and it's an introduction to requests that you may receive in primary care for a client for shared care and for prescribing of S8 stimulants. So our case is a boy that I'm going to call Danny. And again, the intention of this case is not to provide an in-depth history immediately. The intention is that you may know Danny as one of your many pediatric patients. And so the information in this seminar is intended to be a summary only, a background into this young person that you have the ability to read in the few minutes before he comes into your clinic room. So Danny was first assessed with the Child Development Service Pediatric Clinic when he was just 4, and had presented with early childhood language delay and some concerns about his social communication, so his interacting with others in verbal and non-verbal ways, and also his emotional regulation. Because of those presenting symptoms, autism was considered first off. But after gathering evidence from daycare, from observing in the clinic room, from undertaking a developmental assessment, it was decided that there wasn't quite sufficient information to proceed for an autism assessment, and the intention was to monitor. And in 6 months' time, he was showing really positive progress in all areas. At 6 or nearly 7, Danny had had ongoing support from a child development service social worker, and now the predominant concerns had moved towards attention, memory, organization, hyperactivity, and those persisting problems with regulating his emotions. And it then comes more to attention that there's a family history of ADHD. So further investigations that we'll go through later in the seminar, and liaison with school, which is very important, was undertaken to see if Danny would subsequently meet the criteria and meet the clinical picture for ADHD. A month later, this diagnosis was confirmed, and he was commenced on a trial of short-acting stimulant medicine, with methylphenidate being the first one tried. He was subsequently reviewed really quite regularly, so every 3 to 6 months. And at 8 months, Danny was assessed as being eligible for shared care with his GP. So these are the criteria that we think about, certainly within our paediatric service, for a young person that may be appropriate for shared care, for management and prescribing for ADHD. So firstly, the ADHD has been confirmed following comprehensive assessment. That management of symptoms with medication has been started and continued, and there's evidence of improved function at school and at home. That the dose and the type of medication has been adjusted and has been stabilized. So there's been no changes within at least the last 6 months. And importantly, there's no current adverse medication effects or any really significant comorbid conditions, which we would feel would require more frequent specialist pediatrician follow-up. And importantly, I've also cut in and popped in Danny's growth chart, because it's really very important that we monitor the most common side effects that occur with stimulant medicines, which are growth and sleep. So, coming back to your day-to-day practice, your practice should hopefully have received clinical letters from review appointments, importantly through Danny's kind of progress through the Child Development Service, but most importantly from the most recent appointment. You've also received a letter requesting participation in shared care for ADHD, and you will have also received a stimulant medicine monitoring pro forma, which outlines the information that we require to be sent back to the treating paediatrician. We're now going to move on to Claire, who's talking a little bit about the role of GPs for ADHD identification in primary care.
Thanks, Rona. So just a kind of brief overview of when in your kind of clinical setting might you think of ADHD, or, obviously when parents come and chat to you, what kind of things might be what they are looking at. So the key presenting features in children and young people, and also identifying the impact on daily function for the symptoms of ADHD. So what does ADHD look or sound like? There's, I'm going to leave all those up on the screen. I'm sure anyone who's a parent will know that they've said those things, at least a few times to their children over the years. But this is kind of like, is this always what you're saying? We need to be aware that ADHD can also be under-recognised in girls and women, and that they are generally less likely to be referred for an assessment for ADHD, that they're more likely to therefore have undiagnosed ADHD, and also more likely to receive a incorrect diagnosis of another mental health or neurodevelopmental disorder like anxiety or a depressive disorder. So that's kind of what it feels like to the parents, and maybe the school teachers and things like that. And there's a study from, a very long time ago now, I guess, in the 1990s, which compared, controls with children with ADHD, and they were more likely to be argumentative with adults, to blame others, to be touchy or easily annoyed, to lie, and to steal. And that is important that we don't jump to a conclusion of, a naughty child, which, you might sort of look and see that child is just naughty or bad parenting, that we actually think about kind of underlying neurodiversity. So in terms of the high risk groups, and when ADHD in children is most commonly associated with, there were some randomized controlled trials where there's 12 high risk groups explored, so some reasonable evidence, and 8 had significantly higher risk of having ADHD than the controlled groups. So these are ranked in order from highest risk to lowest risk, but still increased risk. So children with autism spectrum disorder have the highest risk of having comorbid ADHD. Children in out-of-home care, those with epilepsy, intellectual disability, oppositional defiant disorders, so that's, exploring other kind of mental health diagnoses, as well as anxiety disorders. Children who are preterm, and those with tic disorders all have much higher incidences of ADHD. So if you have a child that has these pre-existing, then it would be reasonable to think about it. Having said that, there is no current evidence for universal screening in children without sort of morbid kind of risk. The most important thing, I guess, in terms of ADHD is lots of kids will have traits of these kind of things. Like I said, lots of parents will have, said these kind of things to their children over and above or over the course of their life, but is it having a functional impact? And I think it's very important to look into that. So what does that look like in terms of academic or at schooling? Maybe they've got poor working memory and they have difficulty following instructions, difficulty with organisation, maybe unable to take the right equipment to the right place. They might quickly give up and become disruptive and have poor impulse control. So they don't maybe check their work, maybe they rush through it, or they might blurt out an answer. The social impact, again, as Rena sort of discussed, this is the interaction, kind of peer-to-peer interaction. So they may really have difficulty with inattention and poor working memory, and they not understand kind of rules or kind of social norms in the games. And they might get it wrong and be rejected, or they might act impulsively, and other children might view that as being mean. They might be, physically quite reckless and irritating and disruptive to the children next to them. And there's a large family impact. So parents often confuse about their role because the child with ADHD seems very dependent. So, you have to organize things for them. You have to do this, and unable to do things in a kind of developmentally appropriate time. As sometimes there's a family history of ADHD, and then parents with ADHD often kind of thrive in situations where there's inconsistency and irregularity and creativity, but that is unhelpful for the structure of managing a child with ADHD. There's a lot of stigma placed around putting children on medication. Parents often blamed for their children's behaviour. It's often blamed on poor parenting and not on the underlying neurodevelopmental kind of issues. And siblings of a child with ADHD often feel like they're in the combat zone. There's lots of conflict within the family. So in addition to kind of recognizing that, or thinking about, does this child have ADHD, it's really important to explore all other causes of kind of symptomatology that might overlap with ADHD, or things that can be kind of helped within that. So looking at their developmental progression, so do they have any language or learning or cognitive deficits, any other neurodevelopmental disorders. As we mentioned, ADHD co-occurs very commonly with autism spectrum disorder, as well as tic disorders. Any other coexisting mental health? So is there either coexisting anxiety or coexisting depression, or is this all explained by anxiety or depression? And their physical health. So are you optimizing things like their diet, their sleep, which comes a lot into it, especially on different medications, any nutritional deficiencies, and then other kind of standard hearing checks and vision checks, and making sure that there are not other reasons why this child is distractible or behaving differently in school. And are they having seizures, particularly things like absence seizures, which might be, seen as inattention. Genetics is a large risk factor. So children of parents with ADHD have a much higher risk of having ADHD themselves, but also intrauterine exposures, so to substances and alcohol. Preterm birth, as we've mentioned, is one of the higher risk groups. And then other traumas like adverse child experiences. And in particularly children that are in out-of-home care. And looking at the parental factors as well as the child factors. So there is their parental mental health issues or parental trauma in addition. And now their bullying or substance use, especially in a kind of adolescent, that might be either coexisting or a primary diagnosis instead. So next, Rona, we'll talk about ADHD assessment and diagnosis and management.
I'll unmute myself. Thank you, Claire, for that. Again, as I mentioned at the beginning of this talk there, we are all aware of the changes that are happening across the country for kind of changes to the format and the personnel involved in ADHD assessment, diagnosis and management. So in this webinar, what we're focusing on is the process that paediatricians and psychiatrists within WA go through in a standardized way. And essentially it's a way of very putting in a concise way the different aspects of assessment, because there is much more detail and much more nuance in every assessment that we do. But in this very short webinar, we want to have things that you can take away and remember. So the aim of this is really to explain the key steps that are undertaken in a comprehensive assessment of ADHD, thinking about all the things that Claire's just talked about. Um, we're also really aware that GPs have got a really wide skill set and you manage many more conditions than specialists do, and often safely and really well. So our aims for this section are to outline the key steps taken in specialist assessment, particularly around the resources that we use and the information that we gather. And it's really important because between 6 and 8% of our Australian children have ADHD. So that's 1 to 2 kids in every school classroom. And so it's something that will, as you're all experiencing and as you're all coming to this webinar to gain further experience in, it's something that will be in your primary care practices. I've used this picture of the elephant and the blind men because we still do not have a definitive scan or blood test or really kind of binary way of diagnosing ADHD. We're recognizing that there are a collection of symptoms, presentations, and co-occurring factors, and it really depends on the lens through which you look. We do try and take a stepwise approach, which is supported by all international guidelines. So there's a clinical and psychosocial assessment. There are observations and reports taken from settings outside of the family home. We do use standardized rating scales as a way of gathering information, but not as a primary tool for diagnosis. So it's always making sure that this is never something that you tick the right boxes for and you have the diagnosis, but it's something that adds information. And as Claire mentioned, co-occurring conditions are incredibly common, and about 70% of kids will most definitely have other issues going on. We've also really got to think about what our expectations are for the child, because symptoms have to be in the context of their age, their developmental level, and their intellectual ability. It's really important to understand that your prefrontal cortex, which helps to monitor and manage your regulatory functions of your brain when you are first born and within the first 5 to 6 years of your life, is really not very effective. And so we don't expect 2-year-olds to sit still and do their maths homework because it's developmentally not appropriate. We're also really aware that through other developmental delays, we have to really think about the developmental age of a child as well as their chronological age. At school age, there is some talk about neuropsychology assessments, understanding cognitive ability and other aspects of executive function. Lots of research has shown that that's not essential for ADHD diagnosis, but it does provide really quite useful information for differential diagnosis. And we also have to be clear, particularly for those individuals, such as females, that might fly under the radar, but people do develop strategies to manage their own symptoms up until a point at which the demands overwhelm their ability to manage. So we always have to ask about how the child or adolescent is functioning, but we also have to ask about the child or adolescent in the context of their family, because it's a big strain on families and carers to be a super parent for kids that need additional support. The rating scales that we use are well, certainly the ones within the Child Development Service, we use subscription ones. So we use the Connors 4 or the Connors Behaviour Rating Scales, but there are rating scales that are free to users. And so the Vanderbilt is free. The SNAP scale is essentially a symptom checklist. And so that is often helpful for monitoring and for looking at drug responses, but not necessarily to support a diagnosis. This is actually from our case study, Danny, but this is the information that is presented in a graph format from this Connors questionnaire. So on the left is the parent reporting and on the right is the teacher reporting. The symptoms are first divided into themes rather than diagnoses. And so again, if you look really closely and if you remember statistics from mid-school, a T-score between 30 and 60 is typical, 60 to 70 is beginning to be raised, and above 70 is significantly raised. And so for our young person, you could see that in the domains of attention, impulsivity, hyperactivity, and emotional regulation on the family scale, they're all significantly raised. On the teacher scale, they're beginning to be raised, but we often see that there might be differences between environments, and we'll explore those later. Importantly, there's a section on function because there must be functional impact to consider something as a disorder. And then symptom counts, the verbatim DSM criteria are hidden within the Connors. And so when people answer that in a positive way, that then gets counted in symptom counts. And there are minimum symptom counts to officially be diagnosed with ADHD using the criteria. So the DSM is a very thick book for anybody that remembers using books before everything was on the internet, but the criteria for ADHD haven't necessarily changed for the last two iterations of DSM-5. Essentially, there are 9 features of inattention and 9 features of hyperactivity and impulsivity, and to meet a criterion or to meet an area, you need to have 6 or more symptoms of inattention or hyperactivity or both. Just a small learning point, but there aren't 3 types of ADHD. Essentially, ADHD is a broad spectrum of presentations, but there are 3 main presentations, so predominantly inattention, predominantly hyperactivity, or both inattention and hyperactivity, which we call combined subtype. And I guess it's important to know that the term ADD hasn't been used since the 80s, it still floats around, but essentially we would now call it predominantly inattentive ADHD. Management of ADHD, interestingly, hasn't necessarily changed for quite a large number of years, but it's always important to continue to research and continue to gather evidence. And the Australian evidence-based guidelines are actually the most recently published in the world, so the most up-to-date, and they came out in 2022. The pillars of ADHD management are education, parents of kids, of caregivers, of teachers, because it's something that we all will manage and encounter throughout all of our environments. It's really important to support the supporters. So really think about parental well-being and making sure that they are in the best place mentally, physically, emotionally to manage their kids. That families are involved in management goals and in goal setting, because it's all very well a specialist telling you what to do, but you won't follow through unless it's something that you feel internally motivated to change. And again, the essence of ADHD management is multimodal, and lots of studies have shown that. So a combination of lifestyle changes, non-pharmacological interventions, and pharmacological interventions. We are going to go through all of these in webinars 2 and 3. So again, this is just a broad brush, but the Australian guidelines looked at the most up-to-date evidence and reviewed the evidence in terms of the strength of the evidence to recommend something. So lifestyle changes are recommendations. So optimizing sleep, optimizing physical health, optimizing nutrition, screen time. These are all things that kind of intuitively make sense for all of us for our well-being. Particular non-pharmacological aspects that they looked at were parent and family training. So although it says there's low evidence for changing the core ADHD symptoms, but there's good evidence for family function. And if you think about a young person, the context of their family function is most important. So it's always really, when you are looking at studies or considering studies, it's not just the outcome of core ADHD symptoms changing, you also have to think about the child within their context. There's low evidence for CBT. Most strength there is for adolescents and adults. And cognitive training, so things like brain games or specialist programs, still not widespread systematic review evidence. And in particular, when the Australian group looked at neurofeedback, as much as the people that promote neurofeedback would like us to feel, there is still no consistent long-term maintained evidence for neurofeedback. So that's something I always tell my families. Again, pharmacological treatment is something that we'll go into in much more detail in later webinars, but there are essentially first line, second line, and third line medications. And again, these haven't necessarily changed very much over the last 15 to 20 years. So there are immediate release and long-acting stimulant medicines, and first line is usually either immediate release methylphenidate, which most people know is Ritalin or Tish, or immediate release dexamphetamine. But we do know that 8 out of 10 individuals will respond in a positive way to one stimulant, and 8 out of 10 will respond to the other. So overall, the vast majority of young people and adults, so 9 out of 10, will respond in a positive way to one form of stimulant or another. So if one isn't effective or we're getting too many side effects, we do try the other before we change to a non-stimulant. And so the non-stimulants that we have available in Australia are atomoxetine, which used to be known as Strattera, or guanfacine, which is known as Lintuna. So talking about shared care, and again, this feels like such a quick gallop through ADHD, but in terms of eligibility for shared care, essentially we're looking for kids that are stable. and are unlikely to have complexity, but we are not magicians and complexity happens. So age between 7 and 18, that they're stabilized on a dose of stimulant medicine, that the dose hasn't been changed in the past 6 months, that we've identified and managed adverse medication effects. And it is really important for shared care relationships, as much as the new stimulant guidelines allow for any GP to prescribe for any individual. We do feel that it's important that information is shared and kept with a named GP practice. And also that the family are invested and consenting to having their ADHD reviews with the GP. With considering which clients might not be suitable, we're thinking about kids that may have a medical comorbidity or a neurodevelopmental comorbidity that necessitates more often specialist reviews, but that doesn't necessarily exclude things like autism spectrum disorder, if that's something that is appropriately supported and the family are managing well and it's not necessarily impacting on ADHD management. However, kids that are on 2 or more psychotropic medications, or kids that have had bad responses to stimulant treatment, particularly if they haven't had adequate growth or weight gain, we would prefer to keep them. But we also have to think of family factors. So families that have had a history of poor attendance at appointments, or if there's any suspicion or concern about lost or stolen medication or kind of misuse of medication. All right, so taking a breather, stimulant prescribing in WA. You may or may not be aware, hopefully you are aware, that the monitored medicines prescribing code was actually revised and updated really quite recently, so in December 2024, and it built on the Medicines and Poisons Regulation Act of 2016. So there have been some changes in the people and the patients that can be prescribed stimulants. So for us as pediatricians, in order to be eligible to be an authorized or approved prescriber, essentially pediatricians can prescribe stimulant medication for ADHD, full stop. Neurologists can prescribe it for other conditions, psychiatrists can prescribe it for other conditions, but for us as pediatricians, ADHD is our only eligible condition. The patient criteria, so those that are eligible for authority to be given for stimulants, are for kids of minimum ages. So for Vyvanse or lisdexamfetamine, individuals need to be above 6, or for methylphenidate or dex above 4. They have to have an approved diagnosis, and they have to make sure, or we have to make sure as approved specialists, that they don't have any of these comorbid conditions that might kind of make treatment more complicated. And this has been lifted directly from the prescribing code. And importantly, within the prescribing code, they have got limitation on the doses or the maximum doses that kids and adults are able to be prescribed. So for Dex, it's a milligram per kilogram per day, up to maximum 60. For Ritalin, 2 milligrams a kilogram a day. And for Vyvanse, body weight dosing isn't recommended, so we start low and go slow. But for all children and adults, the maximum is still 70 milligrams per kilogram per day, or 70 milligrams a day. And so these are all conditions or criteria when authority requests, which is the old-fashioned way of having to fill in a form and asking for authority, that's no longer necessary to do. However, if there are complicating factors, so when the prescriber, patient, or product criteria are not met, we have to apply for an authority request. And if these kids require an authority request, that does mean that they're not eligible for prescribing by anybody other than their approved specialist. So thinking about GPs and actually nurse practitioners within WA, GP specialists, medical practitioners, nurse practitioners can prescribe stimulant medication as long as the patient is under ongoing treatment, that the treatment at present, and we know that this may change, has been initiated by an approved specialist, that the prescribing is consistent with any letters that you've received from the approved specialist or the latest prescription on Script Check WA, and that it's important that when you are prescribing stimulant medicine that you have seen and assessed the young person and that you are satisfied that it is safe and appropriate to continue to prescribe their medication. Within WA, paediatric patients have to be seen at least every 12 months by their approved specialist, and prescribing must be part of a shared care model. there is a note in the code that the specialist can withdraw from the shared care model, and in that sense that they would need to send a written notification to the GP that's been prescribing. And at the moment, the limitations for prescribing outside of the specialist is that GPs are not able to initiate a stimulant medicine, to alter the dose without written authority, or to prescribe for any individual that has an authority displayed on script check WA. All right, so Claire is now going to talk through what's actually involved for a GP appointment looking at stimulant prescribing.
Thank you, Rona. So look, I've just tried to make it hopefully super simple and say what is required and kind of building on what Rona's already discussed. So just a reminder of the case that we're kind of looking at. So as mentioned, Danny has been stable on a dose and formulation of medications, and there's no current adverse effects or significant comorbid condition. And it's very small, that little thing there, but some of the boxes we will, all of those boxes we will fill in, and a few other things to go through. But up there it does tell you the diagnosis and the medication and dose already on there that he's stable on. So in a nutshell, these are the kind of tick boxes that we need to go through. And I won't list them all there because we're going to go through them now. Noting that the prescriber criteria has already been mentioned by Rona, so I'm not going to reiterate that, but just to say that the final piece of that puzzle is that you as a prescriber have to have no restrictions on your prescribing abilities to prescribe S8s or stimulant medications. So, and basically, this is not a really quick kind of turnaround type of an appointment. I know that we struggle sometimes to get our patients on board that this is not just a script, but I really encourage that this is part of a GP chronic care management, chronic condition management plan, and describe it to kind of patients that this is your 6 monthly review in between times, or 2, 3 kind of monthly reviews between the 12 monthly pediatrician appointment, and that you'll need to be seen in person and get all of your parameters done. As mentioned, this is through CDS, but there have been questions come up sometimes with private practitioners, private psychiatrists sometimes saying, the GP can initiate the medication under the WA prescriber code confirmed by the chief chief pharmacist, excuse me. That is not allowed. So the initial prescription would have to be done by the non-GP specialist. And it is part of the code, part of this that you have to have, as Marina said, checked on save script check. First part is really reviewing what are they doing for the ADHD currently, which we will go into more detail about what they could be doing, but essentially just checking in with what are the non-medication strategies that they're doing and refreshing those, and what is their current medication management. The recommendations through AADPA will be the monitor at least every 6 months, including growth parameters, blood pressure, heart rate, and charting that on a percentile chart, monitoring medication effectiveness. So the SNAP 4 symptom rating scale is quite good for that, comparing to baseline. And then any of the issues that are identified with any of those need to be fed back to the co-prescribing pediatrician in this case. So, standard height and weight, most of this is then automatically populated on centile chart on your practice software usually. I do remember the height centile because that's important for the blood pressure, and just making sure that it's tracking along that kind of way. The cardiovascular assessment, so if you're looking at the left, it's very small. There are blood pressure levels by gender and height percentile. That's why you have to kind of remember it. So if you're looking down the bottom here, gosh, which I probably have to zoom in on my own screen to kind of see. But in this case, Danny is an 8-year-old boy, and if he's on the, say, 50th centile for his height, then his blood pressure should be less than the 90th centile, which is 112 systolic. And the diastolic for that, if he's in the 50th, would be less than 73 systolic. So it does give you a kind of good range of what that looks like. Any new hypertension, which is a side effect, would need to be kind of looked at and reported. On the right of your screen, you can see the cardiac indicators, and these are things that really should have been addressed before they were even started on stimulants, because these things like history of congenital heart disease or sudden death in a relative under 40, etc., so any kind of cardiac symptoms need to have been cleared by a cardiologist before they are eligible to start on stimulants. And it's worthwhile noting, just in general practice, that an ECG is not needed before starting stimulants or atomoxetine or guanfacine unless the person has any of these particular features, or there's a co-occurring condition that's being treated with medications that may pose an increased cardiac risk. So, for example, QT prolongation. It's important to then, as it said, go back and have a look at the medication effectiveness. So, I mean, we're on a medication. We are first trying to do no harm, and we want to know that it's actually effective to continue on. And the SNAP-4 can be really useful for that. So briefly, it goes in, it's got questions 1 to 9 are the inattention subset, questions 10 to 18, I think, is the hyperactive subset. And really, it goes through the targets for what that looks like, but it would be best to compare it with baseline, as in pre-stimulant medication. So briefly, and I know we're going to look into this into more detail in the medication webinar, but the adverse effects that you are looking at, Rona, and I've sort of alluded to already. So growth is a really big one. So appetite suppression is very common, and slowing of growth or even weight loss really needs to be escalated and reported back to the pediatricians involved. Their behaviour in general, because some children just don't do so well on stimulants. Are they very irritable or anxious? Do they have a low mood and other sort of comorbid things that are going on, and tics as well? Look. Sleep is really important to ask about. A lot of the kids have delay in sleep onset that is worsened by stimulants, and some have insomnia, and a lot will require sort of medications then to help with sleep, such as melatonin, which is a separate controversial issue at the moment. There are two kind of transient, or mostly usually transient, side effects of headache and abdominal pain. And usually they are within the initiation of the stimulants, or if there's been a dose increase. So you wouldn't normally see headaches and abdominal pain related to stimulant medication when you are continuing a stable dose of medication. So if they do present with that, it would be important not to necessarily blame the stimulant, and it would still do due diligence and look into that. Seizures is interesting, as we mentioned. There's a very high risk in children with epilepsy of having comorbid ADHD, and actually having seizures is not a complete contraindication. And the increase in seizures usually occurs in the first 30 days or with initiation of treatment, but there's actually no increased risk of seizures found for continuation of treatment. And then just ensuring that there's, which I think GPs are very aware of, no kind of risk of diversion. Are they replacing scripts early, or are there scores such that it looks like they're not even on the medication. In addition to the recommendations and what is allowed to be prescribed from the monitored medicines prescribing code, we also have to look at PBS criteria, which in the child development service is usually met because they are children, and that's the main criteria for a lot of these medications. But also, just for reference, they don't have the same access to sort of, subsidized or free medications for private indications in the child development service because they're a community-based organisation. So they have the same prescribing restrictions that general practitioners and would have. As Rhonda mentioned, the first line are the immediate release, so methylphenidate or dexamphetamine, methylphenidate being Ritalin. These really have minimal kind of PBS, except that you have to have a diagnosis of ADHD. Lisdexamphetamine or Vyvanse has more restrictions. So in addition to a diagnosis of ADHD, that diagnosis, you need to note that the child needs more coverage in the day than a short-acting or immediate release kind of stimulant might give them, but they also need to have been diagnosed in childhood, so before the age of, between the ages of 6 and 17, or they have to have a kind of almost retrospective diagnosis of ADHD for Vyvanse. That can be made if they get an adult ADHD diagnosis made, can be looked back retrospectively. Strangely enough, for long-acting methylphenidate, so Ritalin LA or Ritalin LA, there's no such retrospective diagnosis on the PBS. So they really have to have been diagnosed between the ages of 6 and 18. We go to script check and the stimulant medication criteria, which I'm not going to go through because Rona's already done it, but essentially the difference between like in a concept of what it was pre the December and what it is now is that previously all stimulants had to apply for an authority to prescribe. All patients had to apply for an authority for a stimulant prescription rather. So there was this so-called authority. Now really it's only if they don't meet these stimulant criteria that an authority has to be applied for. And in that case, if they didn't meet criteria because they were either too young, so under 6 for Vyvanse, or they had a comorbid condition, like they previously had a stimulant-induced psychosis, then this the flag on the right is an example of that. There should be an alert come up, and they will also, under the authority box, you can check that, and they should have an authority, but it is only for one prescriber. So that can't be then, you jump around GPs to do that if they have had a authority given by the CEO because they've don't meet criteria generally. So just to say, in terms of monitoring ADHD in Danny, so we've checked the prescriber's criteria, which we all meet, reviewed his current management and his growth, height and weight, his cardiovascular parameters, so his blood pressure and his heart rate, blood pressure being on a centile chart, the medication effectiveness, adverse effects, and PBS criteria. We've checked script check WA, we've checked the dose is the same as what we have in the letters and prescribing the most recent dose. Oops, sorry. And then that's our consult in a nutshell. In the CDS, we would fill out the little the requirements. So we've already done all those when we've done our consult. and just fill out these things and send them back to the pediatrician so that can be monitored. And then the plan would be to escalate to the CDS pediatrician if there were things that were out of our comfort zone, or if there were new adverse effects of the medication, or even something that would require reporting to the script check authority. I'm going to hand over now to Jamie Lee from WAFA, who's going to have a quick chat about the clinician assist pathway.
Perfect. Thank you, Dr. Bowden. And I think actually what we will do now is it's a really good time to do questions because we've had quite a few come through, if that's okay. So I'm going to jump straight into that section before I get into the clinician assist stuff. So the first question that we have is, do you offer telehealth particularly for regional children?
Is this a question for the Child Development Service?
I think so, yes.
Yeah, I'll answer it as though it's for the Child Development Service. So, so if you're not aware of who we are, so we're a very large public provider of developmental services across Perth Metro. And so there are child development centres kind of scattered across, so as far north as Joondalup and as far south as Mandurah. But for regional children in the public sector, then their kind of developmental services are provided by WACS, so the WA Country Health Service with visiting paediatricians. And so at present, we as a kind of metropolitan service aren't offering telehealth appointments for regional kids, but we do have kind of ongoing links with WACS. And so the hope is that there's coverage, but I fully acknowledge that the coverage for regional kids is not as comprehensive as it is in Metro.
Perfect, thank you. And I think this may also be another question for you. What is the waiting list like at your clinic?
So always controversial and usually in the newspaper, but as a very large service that is free to consumers and free to families, we are experiencing huge numbers of referrals. And so our waiting times vary across the service, but they are long, particularly for school-age kids. So funding has always been prioritised for younger children, and they often get a higher priority. So for school-age kids, and particularly referrals around attention and concentration, then they might not necessarily be triaged as highly. And so I've been working, my project, the ARC project, has been working on ways that we can improve waiting times for kids with ADHD, because we know that it's something that we can see, assess and intervene with. But we are up against other societal pressures. So there are other things that are happening in the community that are leading to a huge number of new referrals. And one of our ways of trying to manage the throughput, because once we recognise and diagnose ADHD and are holding on to these kids for stimulant prescribing until they're 18, is that we become incredibly congested. And so developing our co-working policies and partnerships with primary care is one of our hopefully important strategies that we can help create space for the new referrals coming through. But it is a constant discussion point at every single meeting. Thank you.
I can imagine. Thank you. The next question is, does a child or adult always need to be seen in person for continuation of the stimulant scripts, despite having seen the child or adult for previous similar repeat prescriptions?
I can answer that, I guess. So obviously it's in the prescribing code that kids need to be seen at least every 6 months. But the reason that we require people to be seen in person is for that monitoring of growth and adverse effects, particularly for kids, and because they grow and they change so quickly. If you don't see a young person for 12 months, their weight could have gone right down. And so these periodic checks are to catch that. So yeah, it is a requirement that you do need to see them, even if you've seen them before.
Lovely. The next question is, what if you don't do ECG and they turn out to have WPW and are put on stimulants?
Very good question. I think when they've done really big research studies looking at, is there a role for ECG screening of all individuals that are started on stimulants, I think that it wasn't found to be beneficial to do it straight off the bat with no other symptoms. Missing stuff is always a risk, but that's a risk inherent in medicine, I guess. So if it's something that happens, then it does. But the the general guidance across all international guidelines is that we don't routinely do ECGs unless there's kind of family history or personal history that indicates that there might be a cardiovascular risk.
Cool. Another question that we have is, will the baseline SNAP IV be sent to the GP for comparison?
That's definitely something that we can work into it, because I'm working on our communication documents and I've seen further down or further above that actually it's not necessarily coming through in HealthLink very well. It's not necessarily part of what we're sending currently, but I think it might be useful. I guess what we're looking for SNAP scores is whether if kids have got symptoms that are moderate to severe on their current medication, then that would indicate that they would need to kind of go back to their specialist for a medication review. But yeah, good question. I'll have a look at it.
Perfect. All right. The next one is, and this I think one is for Claire. So can a GP not initiate medication for ADHD?
So no, in WA, the current medicines code is that a GP cannot initiate, as in give the first script for a stimulant medication for anyone with ADHD.
Thank
and
you.
The next one I can see as well, which is if all the prescription criteria are met, and you don't need an authorization, can any GP in the same practice prescribe for the patient? The answer is yes, any GP in any practice can prescribe for the patient if they are meeting the stimulant criteria and all of the things we've mentioned.
Perfect. This is another question from a participant that says, I work in
Daliella.
Yeah. Okay, sorry, I might have butchered that. So where should I refer?
Yeah, so WACS does have the child development services in different areas. So in Bunbury, which is near Daliella, I believe, is the Hudson Road Clinic is the child development service down there. And then there's Naturalist if you're down in Bustleton, and there will be a few kind of around the space. So they all get referred through to the local community child development, whatever's called the child development service, but you can always discuss with your child health nurses that are nearby, because they will be aware of the developmental visiting developmental services that come to the area.
Lovely. The next question is, who triages the referrals to public clinics?
So it looks as though the person asking questions may be in Geraldton, but certainly in the child development service, we've got centralised referrals, and so it comes to our central intake and then gets allocated to local centres, but there are kind of triage criteria that are followed.
I'm aware of time, but I just want to touch on some that are in the Q&A chat as well. One question is, charting weight is routine, but is there a threshold where stimulant medication is ceased? What about kids who are overweight and or tall for age before starting treatment?
So threshold where stimulant medicine is ceased. So in that context, perhaps that might be where there's persistent either poor weight gain, so their weight is plateauing, or that they're losing weight. So my usual one is if they've crossed 2 centiles on a standardized chart. So usually what's the growth chart that we use? The CDC growth charts. However, we also look at BMI and we look at generally what their starting point was. Kids that are overweight and or tall for age before starting treatment, then again, it's looking at their overall health. Kids being overweight is not a barrier to starting stimulant medicine, but again, it just takes management. So if we're concerned about a child's starting point or we're concerned about weight, generally they're not the kids that we would pop out onto shared care. And in the things that Jamie will go through, when you're looking at weight and looking at progress of weight over time, if you're concerned that there's poor growth, then that would be where we recommend going back to the specialist for review of medications.
Perfect. And I will just squeeze in one more question. Do you request urine drug screens?
Oh, so interesting. So it's just because one of our guys did a project here, but urine drug screens used to be mandated in the prescribing code prior to December. And it used to be that every adolescent and adult would require a urine drug screen every 12 months. Somebody did an audit as to how often we were actually doing that, and our adherence to that was quite low. And subsequently in December, the newest iteration of the prescribing code is that it's a recommendation, but it's no longer mandated. But we are very sure that use of illicit substances can increase the risk. So stimulants in the context of using other drugs of abuse is a significant risk for psychosis. And so if there is any concern about that, then we would do a urine drug screen, but we just do a lot more chatting with the family and kind of doing it in a judicious way. But thank you for the question.
Perfect. Now, I know we have a lot of questions still here left, and I'm aware of time. So, Dr. Bowden, Dr. Kelly, would it be okay if maybe we email these participants responding to their questions after the session? So thank you for your questions, guys. And for the ones that haven't been answered, we will 100% get back to you on those. I just want to, before we finish, also mention Clinician Assist. If you're not familiar with Clinician Assist, it was previously called Health Pathways. And on Clinician Assist, we do now have a pathway for ADHD in children and youth. You will get a copy of these slides, so it's okay if you haven't managed to have a full look. But please, if you haven't already, you can jump onto Clinician Assist and register now for access to that so that you have access to that pathway as well. And we have gone through our questions, which has been great. Thank you both so much for answering, and thank you everyone for popping your questions in the chat. That's been really great. And I would just also like to plug our next session, which is on the 22nd of October, where we're going to be looking at co-occurring conditions with ADHD and the functional impact of ADHD. And we're also going to be looking at non-medication approaches and psychosocial support for patients and families. So please, if you haven't already, I have left the link for the registration page in the chat so that you can register if you haven't already. And I've also got a QR code on the screen, and that's just to our feedback survey. So we'd really appreciate if you could take some time just to give us a bit of feedback in terms of how you found the session and any future topics as well that you may like to see. And on behalf of myself, on behalf of Dr. Bowden and Dr. Kelly, we wish you a wonderful evening.
Great. Thanks very much, everybody.
Thank you.
Bye.